Thank you very much, Mark, and good afternoon, ladies and gentlemen. I'm very conscious that I'm the last talk between here and the Bull and Bear, so I'm promising to keep this on point. But as Mark and Francesca and I were thinking about this, there are quite a few things to cover here as we think about the plethora of exciting options that we have. My remit from Mort and Ruben, I'm very grateful again to Mort for the kind invitation this afternoon, was to how to make sense of the many options available. And I think Francesca summarized it beautifully by saying a door has opened in the last decade for sure and continues to show an incredible horizon of choices for us. And I think that's an extraordinarily positive thing, obviously. But as we go forward, it's become, I think, a sort of best case challenge. What do we use, when, why, and how many drugs do we use in that setting? So by way of background, perhaps it's worth mentioning that, or re-emphasizing, that this is a highly heterogeneous disease, and we understand this from clonal tiding, we understand this from the incredible genetic instability of myeloma, that this is an extraordinarily mutated disease, particularly in relapse. For example, in whole genome sequencing, we can show that at diagnosis there can be as many as 5,000 mutations in any one particular patient's disease, and then at relapse that can magnify to 12,000 mutations, and beautiful data from my colleague Nikhil Munshi in our team. And I think when you think of that, you realize therefore in the relapse setting, number one, disease has to be guilty until proven innocent, and second of all, we need to throw a very big net around the illness quickly in most of our patients. So with that by background, I think the good news is that we have a big net and it's getting bigger all the time, and you heard beautifully from Mark and Francesca about the immunotherapeutic revolution that we're enjoying. But I think it's important to recognize the sobering truth around myeloma still, of course, notwithstanding the extraordinary impact of Daratumumab and other approaches, but we see early deaths in high risk, and of course, to date at least, we're struggling to find a plateau, although I agree that I think we may be seeing the first clues of that with the monoclonal antibody approach. As we think about factors affecting treatment decisions in our advanced patients, just a few sort of principles to share. Obviously, the impact of improvements in survival has been driven by the success of initial therapy and maintenance, the ability to keep patients on therapy, to essentially immunomodulate, in fact, and at time of relapse to then have adequate and successful therapies that can salvage our patients accordingly. In reality, however, still, when we're in the advanced setting of relapsed refractory disease, we face an enormous challenge. Obviously, this is seminal data from Shaji Kumar from some years ago now, but it really helps frame the discussion. Once proteasome inhibition and immunomodulation has failed our patients, we then have a struggle on our hands. It's important to recognize Shaji's original data, which showed that overall survival after PI and IMiD failure is around 12 months, and that's even with adequate therapy or a therapeutic strategy. And in fact, if you don't treat patients in that setting, his cohort analysis showed that survival was truly dismal at just 3 months. So I think I show this to really emphasize the point that in the last 5 years or so, we've really seen some extraordinary changes and advances. A couple of principles to share. I think critically, rational combination strategies make sense, and what I propose to do in the next few minutes is walk you through the phase 3 data that actually validates that approach. Moreover, of course, we have next-generation immunomodulators such as Pomalidomide, which have made an enormous difference. We have the second and third generation proteasome inhibitors, those that are approved, Carfilzomib, a true game changer, Elotuzumab coming hot on its heels, with arguably a different profile in terms of its activity and tolerability, but obviously some very promising data there as well. And finally, as we've heard so nicely, the real impact of the antibodies, which I will touch on just to sort of re-emphasize the point, but move through fairly quickly. Now, this is the NCCN guidelines from the beginning of this year. And again, it emphasizes that in the US at least, we're jolly lucky to have multiple choices we can use. How to make sense of this, of course, becomes a challenge. And I hope to in some way guide you in this process. This is a schematic that basically brings together FDA-approved therapies in this setting. And I just show them because I think it's remarkable that we stand here in 2016 with so many. But as you can see, their sort of linchpins are the PIs, as I've mentioned, the next-generation proteasome inhibitors, the monoclonal antibody Daratumumab, Elotuzumab in combination, HDAC inhibition with Panobinostat, and in that same context, of course, the advent most recently of Dexamethasone as a recent approval last year, and of course, with the phase 3 data from the Tourmaline paper just published. Now, obviously, since then, we've seen yet again the big surge forward with Daratumumab in combination. So already this paradigm from last year arguably is out of date. This is a very nice summary of the mSMART guidelines from our colleagues at the Mayo, and I think it's actually very helpful. Essentially, it's a revised adaptation of their guidelines from just a few years before, but I think it's particularly useful. And what it shows you is that essentially you can revisit drugs in combination, you can think about antibodies rationally according to line of therapy, and you can also recognize, as Mark touched on earlier, the whole concept of your triple refractory and quadruple refractory, what may be your best regimens. Personally, I'm not an enormous fan of VDT-PACE or combinations like it, but I do recognize that it's active. But I would propose to you that the combinations like it with antibodies added arguably will take the place of this particular box. But suffice to say, this represents, I think, a sea change in what we have available for our relapsed refractory patients as a platform that can then be followed by the immunotherapeutic strategies. So with that in mind, to sort of focus our thinking, I wanted to sort of emphasize the key targets, and I know that Ken touched on this morning, but essentially excess protein production is obviously a key backbone therapy. Genomic abnormalities targeting that become very important, but as I've shared with you, given the extraordinary mutagenic thrust of this illness, we have to recognize how broad that is. And I think restoring anti-myeloma immunity, therefore, constitutes arguably a genetically agnostic approach that can provide us with a real way forward. So these are the summary of the current and future directions that we have, both in the context of new PIs, Carfilzomib and Dexamethasone approved. I do want to bring attention to Bortezomib, third-generation proteasome inhibitor, which I think has considerable promise. Immunomodulatory drugs, of course, Pomalidomide is the forefront of that, but there are yet more coming. We obviously have the HDAC class, which I personally believe has real efficacy in this setting in combination. Panobinostat is approved, but behind it we have the exciting AC compounds, including 241, which I think hold great promise. The immune therapies, of course, are the true game changer. And again, not to reiterate what's been so nicely said before, but the emphasis on these agents, I think, is remarkable. Personally, in my own practice, I've seen Elotuzumab in combination work after Dara failure, which I think is important. Similarly, Isatuximab, in my view, is a major new step forward as well. And of course, we have the real excitement around the checkpoint inhibitors, both PD-1 and PD-L1 coming. So I think this is particularly interesting and important. In the interest of time, I won't dwell on this, but just suffice to say that upstream there are numerous other drugs that are coming down the pipeline. And I show this slide simply to emphasize the importance of clinical trial participation in relapsed refractory patients in this setting, because real benefit can be derived. As we think about combination strategies too, I simply want to make a point, and I know this slide was shown this morning, but suffice to say, sometimes the basic science doesn't tell the whole story. And if you look at this concept around the way immunomodulatory drugs work, and I think it's very valid, it would suggest perhaps that even if you use a combination of drugs in this setting, there might in fact be antagonism. The opposite is the case, as we've shown, and this has been validated not just in these trials, but subsequently in the landmark ASPIRE study, where Carfilzomib combined with Lenalidomide and dexamethasone resulted in a dramatic progression-free survival advantage in favor of the 3 drugs over the 2, recognizing that with the conclusion of Carfilzomib-based therapy at 18 months at that time, the curve started to narrow again, but obviously if Carfilzomib therapy can be continued, the argument I think would be strong that this clinical benefit would be even further sustained as we go forward. So in that context, the combination strategy of PI plus immunomodulation I think is now firmly validated, and 3 drugs over 2 I think is a key forward direction in that regard. The Dexamethasone work led by my colleague Philippe Moreau and the Tourmaline study group has also validated this concept with a PFS difference that's become apparent over time. And I think this is a very interesting study for a variety of reasons, but in the interest of time, I want to focus on the fact that indeed this drug does work in the high-risk setting, suggesting that there is real activity from it. But we also recognize that there must be some challenges that we face in terms of dose and schedule with Dexamethasone that we hope to be able to explore further to further enhance its efficacy. But again, a very well-tolerated drug in this setting, again validating the synergy of proteasome inhibition and immunomodulation in this setting. Now, again, informed by bench science, the arrival of the deacetylase inhibitors in this space, I think, has been very important. And I would argue strongly that this is an important forward direction. Now, of course, the panorama work summarized here has led the charge in that regard with, as I mentioned before, important new work coming with the AC241 compound hot on its heels. Suffice to say, we're aware, of course, of the PFS difference when you combine Panobinostat and Bortezomib compared to the control. But I think what's perhaps underappreciated is that in the face of IMiD and Bortezomib failure, the actual PFS difference is quite striking, and the hazard ratio is 0.47. So again, this particular area, I think, is very fertile ground, and as a treatment choice for our patients should not be forgotten. I also emphasize it because there's science here that's also intriguing. HDAC inhibition upregulates CD38. So arguably here there would be a rational strategy for combining HDAC inhibition with immunotherapy in addition to other strategies such as immunomodulators and indeed proteasome inhibition. Now, with that in mind, pomalidomide, of course, has provided us with an enormous gain in terms of a next-generation IMiD that we can offer our patients in the relapsed refractory setting that also has the advantage of being remarkably well tolerated and an ideal drug that we can combine with various other agents. And of course, from the original sort of baseline work to the important 003 trial, as well as the 002 effort, which led to its regulatory approval in the US, we now have a whole platform of strategies built upon pomalidomide, such as Carfilzomib and pomalidomide, other proteasome inhibitors combined with pomalidomide that take us forward. And we'll show you in a minute some of the combination data with the monoclonal antibodies, which I think is equally exciting. So when we think of comparing these trials, and to sort of help you think about choices, I think it's important to recognize that, as Mark mentioned earlier, hazard ratios of around 0.7 are what we've come to expect. I'm going to show you in a minute, of course, that we have hazard ratios that are far better than that in the monoclonal antibody space, but I think it's worth mentioning that obviously tolerability starts to really matter, and we have to think about this in choosing our agents for our patients. So whilst we're looking at very exciting PFS differences, we also have to be aware of some of the side effect profiles that are relevant to considering our relative choices. And just by virtue of example, you can see here with Dexamethasone, Lenalidomide, and dexamethasone that indeed the tolerability is very favorable with this particular platform. Not that it's necessarily unfavorable with the others, but it does point to the fact that we have choices, particularly with the convenience of the all-oral route. This is also a summary of the safety profiles, and I would simply argue that this is important to consider. And fortunately, with these wealth of choices, we have the options to choose for our respective patients. Now, in the next few minutes, I just really want to conclude by bringing together the monoclonal antibody and immunotherapeutic space, which has been so important. Again, you've heard so nicely from Mark and Francesca about mechanisms, so I don't propose to dwell on them, but suffice to say that there have been intriguing new discoveries in this area. And I think, for example, speaking to Daratumumab as the one lead antibody in the CD38 space, recognizing that Isatuximab is hot on its heels, at the same time, we're recognizing new mechanisms with the further study of this drug, which are proving intriguing. Arguably, the resetting of biology, for example, in certain patients may be a real phenomenon with this approach, which may further confer clinical benefit. That being said, we obviously have the phase 3 data from the Eloquent study, which again was presented earlier, so I won't dwell on it, but suffice to say this PFS difference is real, and as Mark pointed out, is really sustained in the responders. Moreover, it is seen clearly in the high-risk population as well, which I think is very, very important. Antonio presented at ASH a very nice study looking at Elotuzumab and Bortezomib, which would not necessarily be intuitively the combination to take forward, but in fact was pioneered by Andras Jakubowiak in this setting, and indeed a PFS difference is seen. So again, this whole construct of what best partners there are is tremendously relevant. What I can share with you is that Elotuzumab combined with Bortezomib and Lenalidomide is showing great promise. And my colleague, Dr. Jacob Laubach, has led a very innovative study of RVD-ELO in the upfront setting as part of the MMRC, from which we have really remarkable results and excellent tolerability in younger patients. Now, what about the CD38 story? Well, again, you've heard a lot about it. I do want to emphasize the benefit of the monotherapy studies, not to in any way underemphasize how important the combinations are, but in your patients who may not necessarily be tolerant of a proteasome inhibitor or an IMiD at any particular time, the use of Daratumumab as monotherapy, in my experience, has been very valuable. So one could reasonably start with Dara in a selected patient in whom you might not wish necessarily to immediately bring a companion drug, and then add your companion drug if needed, because at the end of the day, we're seeing some really interesting data from the monotherapy approach with steroid combinations or in combination at low dose. Well, of course, with the IMiDs, the excitement is very real. This is Torben's original work that informed the Pollux study, and as you can see, the response rate was dramatic, and of course that was the catalyst to the phase 3 information. And indeed, there's no surprises here that when you put Pomalidomide with Daratumumab, the responses are really impressive. And Achai presented a very nice oral presentation at ASH in December, illustrating just this point. So what about the Pollux study? You've heard about it already, but I really want to just emphasize the point that at the beginning I mentioned that there's no plateau. Well, perhaps we're beginning to see a strong hint that even in the relapsed refractory setting, we can start to see it. The subgroup analysis, I think, is very compelling and really points to the potency of this approach, because even in prior lenalidomide-exposed patients, we're seeing benefit with the monoclonal antibody combined. And as Mark touched on, the MRD negativity of this is striking. To be able to see in the relapsed refractory space this kind of MRD data, I think is quite extraordinary, and I think bodes very well for the future, and the overall survival we're familiar with and already is looking very encouraging. And if you compare this then to other lenalidomide-based studies, you can start to see that arguably the combination with a monoclonal antibody, and in particular in this case Daratumumab, is a true game changer. The hazard ratios are truly unprecedented. And in this context, I think we're going to see the fruits of this, bringing this particular antibody and others like it forward into the earlier space even better going forward. What about Bortezomib? Well, Antonio presented this at ASCO at the plenary session, and it was published shortly thereafter in the New England Journal. Even with Bortezomib, Dara is generating remarkable differences in outcome, which arguably might not be necessarily expected. However, it's very clear that the apoptotic mechanism through which Daratumumab works may be very important here. And again, these results are remarkable, although I will stress that unlike Pollux, the control arm here had a finite duration of therapy, so therefore one has to take this into account when looking at these remarkable differences. Importantly, and I think Mark touched on this very nicely, if you move this drug earlier, the results are even better. So I think that's a relevant point, and the response rates are much as we would expect. So the conclusions for Daratumumab and Bortezomib are clear, very similar to what I just showed you with Daratumumab and immunomodulatory treatment in the form of lenalidomide. Arguably, these will be new standards of care in the relapse setting in the relatively near future. As we compare proteasome inhibitor-based approaches across in these phase 3 trials, you can see that obviously Dara, again, does very well in combination with Bortezomib in this setting, and actually, as you can see, Carfilzomib with a very favorable hazard ratio is hot on its heels here, as of course is PVD particularly in the population at risk, and ELO is not too far behind. So the good news is multiple options that we can adapt rationally to different settings to tailor to both disease characteristics and, of course, to improving tolerability. Now, Francesca talked a lot about this, and so I don't intend to dwell on it in the interest of time, but I think this whole immunotherapeutic space is so exciting. And I want to emphasize the emerging role of vaccines that I think will complement what she described so elegantly. And at the same time, CAR T therapy obviously is a very exciting new avenue. My only caution around CAR T therapy is the practicality of the approach. Speaking from my own clinical practice and trying to get patients into CAR T programs, that's somewhat easier said than done in terms of cytoreduction. So I think we shouldn't lose sight of the fact that excellent strategies to reduce tumor burden prior to getting them into these immunotherapeutic platforms is absolutely vital. So whilst we get caught up in the enthusiasm of immunotherapy, I think it's very important to also not forget the critical role of next-generation immunomodulation, proteasome inhibition, cytotoxics, and drugs like it to drive that cytoreduction that we need to get to this particular point. So in terms of concluding comments, I would simply derive this from a paper published by my colleague, Dr. Jacob Laubach, as part of the IMWG, and I especially want to acknowledge the co-authors in that study earlier in the year in leukemia. But what Jacob summarizes here, I think, is a key sort of set of benchmarks for you to think about. When you look at choices, think of number of prior regimens, responses to prior therapy, realizing you can revisit classes of drugs that you've seen before. Remember the toxicities, obviously, myelosuppression, other things being very relevant, but I think we have multiple agents now we can reasonably exploit. Comorbidity is therefore a factor. Patient preference, the excitement now with all oral approaches to treatment is real. Characteristics of relapse are important, but I would always share with you that relapse disease should be taken very seriously and essentially is essentially guilty until proven innocent. So it's important not to underestimate relapse disease, recognizing that there is a spectrum of tempo. Now, the question is 2 drugs versus 3 drugs. Well, I've shown you a wealth of randomized data that suggests clearly 3 drugs is the way to go. However, there are patients in which 2 drugs would be reasonable in my view and perhaps preferred. And I would strongly argue for clinical trial participation being a really important and valuable option, obviously for the field as a whole, but most importantly for our patients. This is a sort of summary of the impact and integration of novel agents. I think you've heard all of this earlier throughout the course of the day, but to just re-emphasize that beyond the immunotherapeutics, there are also obviously new small molecule inhibitors that I honestly believe really should never be forgotten in this context because they remain very important, such as the nuclear transport inhibitors and others, which I think have real merit and are continuing to be explored. This, of course, is a lovely slide to show because it gives you an idea of the real benefit that's been seen. I especially want to acknowledge the contribution not only of our investigators, sponsors, and everyone in the research mission, but also, very importantly, the FDA in this process. And on that same note, look at the future. Lots of exciting things to come. So again, a unique partnership that's built this. It shouldn't be taken for granted, I would stress. Having said that, I especially want to acknowledge those who participated and contributed, and many are in this room. And with that, I just want to thank you for your kind attention.